We respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkwiden, Anishinaabeg, the Three Fires Confederacy, Ojibwe, we respectfully acknowledge that the Windsor Regional Hospital occupies. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation.
Against environmental degradation. Good evening, everyone, and welcome to the first open board meeting of the new year, so September 8th, 2022. I am going to call the meeting to order at 5:04 p.m. Do we have any declarations of conflict of interest? Seeing none, thank you. Can I get a motion to approve the previous minutes? Patty France, thank you. Seconded by Genevieve Shaw. Thank you, Genevieve. Questions or comments with regards to those minutes? Seeing none, all in favor? Wonderful, thank you. So we have had some very sad news today. The Queen of England did pass today. So we're just going to have a couple second moment of silence and acknowledge all of the great things that she's done over her reign. So let's take a few seconds to acknowledge. All right, thanks everyone. And it looks like I may have a slight delay in my speech. Is everybody hearing me okay? Yes, okay, thanks everybody. And just so you know, the flags at both the Windsor Regional, the Met campus and the Elect campus have been lowered to half staff, so, on the Queen's behalf. So to get us started, we are going to go to the report of the President and CEO, David Moucher.
Thank you, Mr. Chair, and welcome everybody to a new board year. Hopefully, some of you have been able to rest a little bit over the last couple of months. Myself, Dr. Saad, and Karen Riddell will be doing a presentation highlighting parts of my written submission, my board submission. For those new board members and even new executive members, historically, up until COVID started, I took our strategic plan and our strategic directions, and I tried to highlight various items we are working on within the organization under each of the headings. To show how we're working towards achieving our strategic directions. And unfortunately, for the last couple of years, I have been unable to do that just because of timing and also, unfortunately, the relevancy. Usually we are preparing for the last 2 years for the board meeting the day of and basically hours before because things were changing so quickly on us. Things have started to stabilize a bit. And as a result, I'm trying to go back to that format and we'll see how long that lasts. So out of that format, though, I am going to highlight certain segments of it. And that's what I'm going to take you through now, along with Dr. Saad and Karen Riddell. So the first thing I want to highlight is Bill 7. There's been a lot of discussion across the province with respect to this bill. It's called the More Beds, Better Care Act. And what that bill is the basis of it is the concept of alternative level of care patients. So what does that mean when you hear alternative level of care? In an acute care setting, it's a designation made by the physician caring for that patient, that they are no longer needing acute care, but they are needing some type of other type of care, short of going straight home with even no home care support. So there could be alternative level of care, is the acronym is ALC. It can be for long-term care. It can be for going home with home care. It can be going to a subacute facility. So when you hear the word ALC, it fits under those types of designations. A certain portion of those patients is what this legislation applies to, and that is ALCs for long-term care, meaning a physician has designated that the patient no longer requires acute care, and as a result is the best place for that patient is in a long-term care facility. And once they're designated, then the work begins, but technically it actually, as you get close to that designation, the work is starting to get the patient and their caregivers ready for the placement in a long-term care facility. Up to this point, and still, the way in which patients are placed in a long-term care facility is based upon them making a decision along with their family members or POA, power of attorney, on their choices. Before, I remember when I started in healthcare, it used to be your top 3 choices. Now it's gone to top 5. And you rank them with respect to availability. And then a determination is made about if they have space, what type of space that might be while you're waiting. Over the years, it's been a complicated process. It's very legislated, meaning individuals are placed on a waiting list, and you can't, short of some, and I won't get too deep into it, a crisis designation, you can't trump anyone on that waiting list, meaning you're on the waiting list and you're ranked in that priority, and your eligibility to get into that home continues as the ranking stays, unless someone passes away or is placed inside of a home, then you move up in your ranking as a result. Ontario, from my understanding, is one of the few jurisdictions that adheres to this and doesn't place a patient in an existing vacant long-term care bed while awaiting for their preferred choice. Is Ontario has allowed patients to stay in acute care and wait for their preferred choice. And I'll, get into the numbers a couple slides later with respect to what that looks like. So I have in front of you a couple quotes regarding this legislation. And the first one is from Minister Paul Calandra, who is trying to explain why now Ontario has decided to move towards this legislation. Like I stated, many jurisdictions across Canada already have it. And basically, to summarize what he's saying is, even though they have added over 3,000 acute care beds to the system over the last 2.5 years through funding, the projections are based upon the upcoming respiratory season that Dr. Saad's going to talk about. We're going to be about 2,400 acute care beds short, meaning we're going to have 2,400 more patients in Ontario than beds in and around January of 2023. That, needless to say, is a problem. At the same time, the OHA, their data suggests that indicates that there's close to 6,000 of these ALC patients, alternative level of care patients in hospital, as of the middle of last month. As I stated, some of them are ALC for home care, some of them are ALC for complex or subacute. They estimate 2,400 of them, 40% of them, are waiting for a long-term care bed. So if you look at our numbers, as stated, since January of this year, 1st, until the end of July, our physicians have declared approximately 276 patients as alternative level of care, not requiring acute care, and qualifying them to be placed in long-term care. These ALC patients for long-term care have stayed a combined 5,300 days, 5,312 days in acute care after designation for long-term care. This is not their whole stay. So when you do the math on that, that equates on any given day to approximately 25 patient beds a day being occupied at Windsor Regional Hospital by ALC patients for long-term care, even though there are some long-term care beds available in the community. So that's 25 beds that are unavailable. At the same time, during the month of August, Windsor Regional Hospital had approximately 22 patients a day waiting in the emergency department for an inpatient bed to become available. So if you look at it as a domino game, I guess you would call it. It's not a game, it's real life here, is you have the ALC patients waiting for long-term care, approximately 25. Then we have 22 patients a day in the emergency department who have been admitted to an acute care bed, waiting to get a bed, but can't get it because there are no beds available for them. That cascades down, if you want, to even the waiting room, because the individuals in the waiting room are trying to get into the emergency department, but can't because these stretchers are occupied by patients already. So the ED staff does the best they can with the space they have to try to facilitate getting patients into the hospital emergency department proper. So it creates a problem. I can tell you these numbers for Windsor Regional Hospital, if you want to look at it, are probably some of the best in the province, meaning the work that we've done here with home and community care and other partners over the last few years has been extraordinary to have this number of 25 being as low as possible. There's others across the province of our size that are into the hundreds on a given day, that they have 100 of ALC patients waiting for long-term care. So I have to give credit to our team to making that number as low as it is, but you can tell it still creates a problem for us. So as stated, also simultaneously is across the province, across Canada, internationally, is as we, I don't want to use the words post-COVID, but as we move towards a more stable part of the pandemic, the number of patients being admitted from the emergency department to a hospital acute care bed has increased. So between January, I took January to June of 2019 and compared it to January to June of 2022. So the same time period, one being, quote, pre-COVID, one being now. And we are admitting from the emergency department 5 more patients a day. So instead of 44 a day, we have now 49 a day between the two campuses. And not only are we admitting more, but their lengths of stay are longer. So they're staying, instead of 6 days on average, they're staying 7.1 days in 2022. So when you compare 2022 to 2019, again, that's some 6,478 more patient days now during the first 6 months of this year as compared to 2019. When you look at that, that means we have pressure of 35 more acute care beds now being needed as compared to 2019. So you take that plus the ALC issue, and you can see where the problem is happening. So if you want to take a snapshot of what we're dealing with right now, like pretty much the last hour, is we have 33 ALC patients designated for long-term care. The 33 of them have waited a combined 973 days in this hospital in acute care since that designation. You do the math, that's close to 3 years of combined stay in the hospital just as ALC for long-term care. At the same time, and we've said this multiple times, is we're operating close to 60 more acute care beds now than we were pre-COVID. And still 18 of those are unfunded, and we're working with the government to get those funded. So what is Bill 7? There's been a ton of discussion regarding it. As stated, this legislation, I can tell you, has been asked for. I've been in healthcare over 20 years. I recall talking about this when I first started. The need for this type of legislation, these types of policies. This is not new. This has been discussed for years and decades. But as I stated, other jurisdictions have put it into place, other provinces. Ontario hasn't for multiple reasons. We don't have time to keep pushing this along, as stated by Minister Calandra. You know, people want to use the word right now, you know, we're in a crisis. I think right now we're not in a crisis. Are we going to be come December or January if we don't do stuff now to get ourselves in a better position? Yes, we will be for sure. So we have to make changes. And again, this is something that's been talked about for years or decades under every single different type of government. And it's being put into place. Again, it's allow for better patient flow. It's a clinical decision that a patient is declared ALC for long-term care. They are going to be able to wait when they go to the long-term care home that is available. They can wait there and they're still in that priority system for their preferred choice. Meaning if they were 5th on the list, they're still 5th on the list, even if they're in a long-term care home. It doesn't prejudice their wait list priority by moving from acute care to a long-term care home. The way I look at it too is hopefully there has to be an appreciation that the long-term care residents or patients recognize that by doing this gets back to the flow issue. If they ever needed acute care again, that ability or that availability is going to be greater. Meaning if they come to the hospital, the chance or the numbers of those waiting for an acute care bed in the emergency department, where I outlined before, will be minimized and they can get to that acute care bed quicker as a result of this. So they will personally benefit as well if they ever have to reattend acute care. And how do we get into this issue? This has been going on for years. There has been funding freezes for decades that have predated and is borne by every single political party. So this is not the current political party's issue, other than they have to be the ones here to try to correct it. And as stated, the current government at least has invested more than 3,000 beds, funding to over 3,000 beds. But this problem and the previous premier from the previous government, when she left government and was asked about her role in some regret she had, and it was her statements during COVID, is she regretted the hard line they took on healthcare funding when she was in office, when her party was in office, and how that has prejudiced the current situation now. So there's plenty, if you want to, plenty of blame to go around. But unfortunately, like I stated, this should have been done years ago, and it hasn't, and it wasn't. And it needs to be done. Now, what we have to make sure happens is clearly this issue of movement of patients to a long-term care facility outside of their region. That is like the last, I put 3 last there. It's probably 10 last, meaning last resort. The chances of that happening are like slim to none. That, you want to talk about crisis, that is like crisis mode for that to happen. So unfortunately, that's what we hear about because, you know, the quote legislation arguably as it's written now allows that to happen. Stated at the bottom here is they're working on regulations and some rules to come out. I assume, and I'm almost positive, that when those rules and regulations come out, that's going to be like a last resort for that to happen. If someone is moving into a long-term care home that is not their choice, it's going to be within that region. Some other things, these are my thoughts, is the costs associated with being in the long-term care, not their choice, should be something that should be heavily compensated, in the sense of their costs are nowhere near what they would be if they were in the home of their choice. It should be reduced. Also, our CFO helped me with some of these. The transport costs, these are some, getting in the weeds, but when the transport costs to preferred long-term care home is addressed, meaning the family doesn't pay twice. So if they move into the home not their choice and they have to move again to the home of their choice, they don't have to pay twice for 2 moves, because technically they would have gone into the home of their choice and would have had one cost. And then the other thing we have taken into consideration is if their home of choice is like 2 days away, within the week away, you're going to try to avoid multiple moves, is meaning you don't move them to a home not of their choice and then move them knowing that within a week it's going to open up, is you try to move them once. So I would imagine that will be in the rules and regulations to minimize the moves. But I can tell you some of these waiting lists are months and years to get into the home of their choice. Generally, they're not days or weeks. And as a result, that's what adds to that number that I outlined before. So again, is this also the magic wand, or we do this, everything's solved, and October, November, December, January, February board meetings, we talk about this and everything is peachy? No, there are multiple issues that need to be addressed. This is just one of them. But if we don't do this one, then yes, we're going to be in a crisis come January. We are going to be in a full-blown one, guaranteed. That's, again, not to say this will, quote, avoid the crisis, but it'll greatly minimize what we're about to face coming into our fall and winter season. So again, this is something that should have been put into place quite some time ago and was not. And when I say quite some time ago, I'm not saying in the last 4 years. Would have been great if we did it, but we're occupied on something else in the last 3 years. But definitely before, there's no reason why they should have not been put into place. And unfortunately, now's the time, and we have to do it and fully support it being done. And as stated, I can tell you there are multiple hospital healthcare leaders that have been discussing this in Ontario for decades, and the need for this. And again, we're going to do our best to make it as smooth as possible for our residents and patients, but at the same time, focusing on those who are waiting for a bed or in the emergency department who need a bed. We just can't focus on one without focusing on the whole. And that's what we're doing as well. So I'm going to pass it over now to Dr. Saad to speak about possibly some projections coming up, as I stated what Minister Calandro was hinting at.
Thank you, David. So one of my old infectious disease preceptors used to say, once you've seen one flu season, you've seen one flu season, and that's it. Because going from one flu season to another can be extremely unpredictable. They each look very different from each other. But one of the things that we do sometimes in North America is look at what did the flu season look like in the Southern Hemisphere, because oftentimes that can give us a sense of what we can expect here locally. So in the Southern Hemisphere, and particularly Australia and New Zealand, who are in their winter season right now, between April and October, you can get a sense of what influenza is, how it's circulating and how infectious it is there, and then predict what it could look like here in our winter months. This turned out to be very analogous, and we mirrored what Australia did for the last 2 or 3 years. You can see from the dotted line for 2021, that pale blue line was nearly 0. And that following winter here in North America, we had nearly 0 cases of influenza. Similarly, the 2020 line looks very low as well, and we again followed the similar pattern. What's concerning healthcare officials and providers in the Northern Hemisphere is what's happening in the Southern Hemisphere now. Two things you'll notice from this graph is one, their influenza season peaked very early. It started almost 1 or 2 months before it normally would circulate. And secondly, the peak of the graph is actually higher than previous influenza seasons. And the total number actually topped out more than 3 times the total number of influenza cases that they've had over the preceding 5 years. So healthcare officials are speculating as to why this could have happened. One reason, if you notice the last 2 years, there were very minimal influenza cases. And so people are saying, well, it's because the general population wasn't exposed to influenza, immunity may be very low. And as a result of the population not seeing a lot of influenza over 2 years, they're now more susceptible to influenza infections. And then the other main vector for transmission of influenza, as we've known for many years, are children. And kids are back in school. Kids are maskless this year, as which is different than the previous 2 years, and they are a primary mode of transmission. So the combination of low immunity to influenza over the last 2 years, combined with maskless children this year, is likely what contributed to the significant influenza rates in the Southern Hemisphere, and something that we are worried is going to happen locally here in the Northern Hemisphere. And that's part of the projections that we're concerned about that David was mentioning on an already strained hospital system. So number of influenza hospitalizations at Sentinel hospitals, again, from April to October over the preceding years. And you'll see the spike again, starting early and peaking early compared to the previous couple of years, where you can see almost a flat line for 2020 and a slight increase in the numbers for 2021. So those, and then of course, the other thing is both influenza and COVID are both respiratory viruses. Since the beginning of the pandemic, infectious disease experts were always warning about the possibility of 2 respiratory viruses co-circulating at the same time, which could spell trouble for hospitals, especially when they're already strained and struggling. And so that's part of the projections and what we're worried about. And you also have to remember, it's not just the respiratory illnesses, because, you know, influenza and COVID can also exacerbate ongoing health issues for many of our patients and lead to serious disease of underlying comorbidities and potentially death as well. So that's unfortunately some of the projections that we're looking for the fall.
Thank you, Dr. Saad. Now I'll hand it over to Karen Riddell, our CNE and Chief Operating Officer. What Karen's going to highlight is one of the ways we are preparing, or have been preparing, technically going back for years, and definitely over the last handful of months, getting ready for what's facing us now, let alone what's coming in the fall and the winter, and trying to offset what some other systems have experienced currently is what is called HHR, Health Human Resources Challenges. So I'll pass it over to Karen.
Great, thank you, David, and good evening, everyone. So just a very brief update on our health and human resource work that we've been continuing throughout the summer, and we've discussed this in the last board year as well. Since prior to the start of COVID, we actually have employed 10% more frontline staff than we had prior to the start of COVID. So we've been very aggressively trying everything within our power to bolster our resources. So some of these initiatives we actually started prior to any provincial programs being available. For example, hiring 3rd and 4th year nursing students. So we've hired close to 500 nursing students since the beginning of the pandemic. We currently have 174 on staff, and we're looking to onboard. We just onboarded another 50, and our target is to have 300 3rd and 4th year nursing students onboarded over the next 2 weeks. These students have really been critical to helping us sustain our operations throughout the pandemic. And also a great benefit to our future recruitment. So many of those nursing students also stay on after graduation and become our new registered nurses and registered practical nurses. We've also, earlier this year, we applied for and were approved as a supervised practice experience program partner. This is a program that's offered through the College of Nurses of Ontario in collaboration with Ontario Health. So we get matched with IEN, or internationally educated nurses, through the provincial system. And we've been able to initiate training with 12 of those internationally educated nurses so far. We've proceeded to hire 3 of them that have successfully completed the program and attained their registration with the College of Nurses of Ontario. And we have 41 others that we're working with and hoping to onboard soon into the program. So this is a great opportunity. There are approximately, I believe, 26,000 internationally educated nurses in Ontario that are just needing to get their registration. So this is probably one of the fastest ways that we can bolster our human resources in Ontario with the nursing shortage. We've also been what we call collapsing part-time clinical jobs into full-time jobs as much as possible. So if we have part-time positions that are unfilled and people are looking only for full-time work, we combine 2 part-time jobs into a full-time job. And this has helped us create an additional 12 full-time jobs that we've been able to fill. And then we also have temporary positions that are posted when someone is off on a sick leave or a maternity leave or perhaps an education leave. And normally we post those as temporary positions, so they're a contract term. They're not particularly attractive for external hires. So we have been converting those into permanent positions, and we'll be balancing those, of course, through attrition, so that we are able to create those permanent positions, including both part-time and full-time positions, to attract new recruits and to also help retain our staff so they don't have to leave the hospital to attain a full-time position elsewhere. So these strategies have been really successful. We're still working very hard and working with our human resource department, and our new VP, Todd Bested, and his team are doing great work with our recruitment and job fairs and our advertising. So it's certainly, we still have some work to do, but we're in a pretty good shape going into the fall and winter and looking at the numbers of beds that we're going to have to operationalize. So that's all for me.
Thank you, Karen. So that is the report, Mr. Chair, of myself, Dr. Saad, and Karen Riddell, our CNE.
Great, thank you. Do we have any questions? I know that's a lot of information to take in. Questions for David, Dr. Saad, or Ms. Riddell? Seeing none, you guys were very thorough, so thank you so much for that. Right, moving on in the agenda, we have the Schulich report from Dr. Jacobs.
Thank you very much, Mr. Chair. I have a very brief report that was already attached to the previous documentation, but really from my perspective, it's the beginning of a school year, which is always exciting for us. Lots of renewal and lots of excitement. We did host a meet and greet yesterday on campus, seeing all of our new first-year students arrive, and many of our faculty members, many of them as original employees, were present. We shared that with the Faculty of Nursing, welcoming the nurse practitioner students as well to the at our meet and greet as well. Overall, we have a lot of optimism for what the year is coming for us, and a lot of excitement with what's happening. The school is undergoing accreditation review in, I guess, 16 months now. So this will be a very busy year for us, collecting all of our documents and making sure that everything is in order. Certainly the best thing about accreditation, besides lots of extra work for all of us, is that it does allow us to point out areas which we maybe have fallen away from, and give us a lot of opportunity to grow and improve. So that'll give us a lot of chances to sort of continue to grow here in the city. And then the last thing I wanted to update everyone on is I've mentioned our international program before. So we mentioned it was approved. We were able to get that launched over the summer. And so we are now accepting applications for international students to study at the Windsor campus. And we'll not know till November how many take us up on the offer, but we're excited to see how that will grow as well. Thank you very much.
Do we have any questions for Dr. Jacobs? And seeing none. All right, congratulations on being approved for foreign students. That's very exciting for the program and the continued growth of the Windsor campus. So congrats. Next up, we have the financial presentation with Ian McLeod, and Ian is our new treasurer for 2022-23/23-24. Geez, wow, time's going by fast.
Thank you, Anthony. Matt, do we have the slide presentation? Great, Matt, if you could move to the next slide.
I don't think that's the right one.
No, this is the wrong one, Matt. This is the operating budget, which comes up under the in-camera.
Dawn, had you sent Matt the other one as well?
I'm going to send it right now again. Let's see.
Thank you. Sorry, that might be on me. I'm not sure.
That's okay.
First meeting of the year, a few hiccups.
You had wrinkle to iron out. It's all good.
How's the rock, Anthony?
Perfect. It's a beautiful province. Ian, do you want to talk about that other item while we're pulling this up with regards to the auditors for?
Yeah, we can approve it in this meeting. It's on the schedule on the in-camera, but
I apologize.
well, I'm actually wondering, should it be approved here because it normally goes public, or do we wait and do it at the next meeting after it's approved in the in-camera?
I have the slides here.
Great.
No need to debate it now.
Okay, perfect. We'll do it in the in-camera.
Public, you'll find out about it very soon, I promise.
No, that's still the wrong one. Hang on.
Matt, I just sent it to you now.
No, I have it. One sec.
Melissa, he's anxious for you to do that budget presentation.
It clearly is. Ready. All good.
Is that right?
Perfect.
Great. Apologies. There you go.
That's okay. Next slide, Matt, please. These are the financial results for the 4 months ended July 31st, 2022. There isn't a comparison to an unapproved budget, which is being presented in the in-camera session to follow this open session. The year-to-date deficit to the unapproved budget is $245,000 for the year from hospital operations compared to a budget deficit of 2.1. The net deficit after building amortization is $657,000. Could I have the next slide, Matt? This slide shows the breakdown of 9.3 million in COVID expenses. Unfunded COVID expenses total 1.1 million due to a few items: the wage differential for nursing externs, sick and isolation costs in July, which are now unfunded, additional staffing in the operative program, incremental PPE, additional shuttle costs, storage of equipment. We do expect that there's a $170,000 gap in medical remuneration to be funded by the government. Revenue shortfalls relate to 3 categories, and these are reimbursed if eligible through COVID funding. The volume-based, quality-based procedures, QBP, neuroservices, cardiac, and wait time. When compared to the budgeted volumes, there is a $3.3 million shortfall. Patient revenue sources are preferred accommodation, both semi-private and private room charges, OHIP technical, the hospital portion, and professional fees and billing for cosmetic procedures not covered by OHIP. Recoveries come from retail operations such as the gift shop, food services, parking, the print shop, and services such as laboratory testing referred from other hospitals. Next slide, please, Matt. This slide goes through year-to-date revenue. Base and one-time funding is 3.6 million favorable due to amounts that have been accrued for known COVID-19 reimbursements. Preferred accommodation and co-payment revenue is 1.1 million unfavorable due to the inability to bill for private and semi-private rooms because these have been assigned for infection control reasons. Patient revenue services is 1.7 million favorable, and this relates to insured patient volume from the ministry, which is paid at the interprovincial rate, which is higher than the OHIP rate. Other recoveries favorable of 769,000 from retail pharmacy are offset by higher drug expenses. Slide 5, Matt, please. This is the year-to-date expenses. Salaries and wages are 851,000 unfavorable year-to-date. This variance includes 1.3 million in COVID sick and isolation pay and 1.9 million for nursing externs and 995,000 in screening cost. Medical and surgical supplies are 238,000 unfavorable due to the increased use of PPE, which was not funded past June 30th, 2022. The medical staff fee of variance is largely attributable to COVID-19 physician payments, which are funded at $1.8 million, with the remainder attributed to additional diagnostic volumes, which are funded via OHIP billings, payment services revenue. Drugs are 215,000 unfavorable. Additional drug expenses in retail pharmacies are offset by recoveries previously noted. Other supplies of 83,000 mainly due to COVID-related expenses such as additional shuttle cost, storage of equipment to implement social distancing. Mr. Chair, I would take any questions at this point for Melissa or I.
All right, questions, comments from the board? Seeing none.
If not, then I would make a motion that the financial presentation be accepted.
Can I get a seconder? Penny Allen, thank you. Questions or comments? Seeing none, all in favor? And nobody is opposed. Perfect. Thank you so much. And then we will move on to the consent agenda. I believe there is nothing. Can we get a motion to?
I will make the motion, Mr. Chair.
Consent agenda. Oh, thanks, Ian. And seconded by Paula Shantz. Thank you. Questions and comments? Seeing none, all in favor? Perfect. Thank you. I think there's a delay in my video, so sorry, folks. I'm a little bit slow. So we will continue moving on. We have the correspondence and printed materials there for your information. Do we have any questions or comments from the board currently? Seeing none, I just did want to bring up one item. Let me make sure I have my details correct here. So this coming Friday, September 23rd, we have the 28th annual Gourmet Food and Wine Gala presented by St. Clair College. All the donations will go to the new acute care facility. So if you are looking for tickets, please get onto the Windsor Regional Hospital website. I think you can get it downtownwindsor.ca. There's probably 22 different ways to find tickets for the event and get to the appropriate link. So again, thank you to St. Clair College for being a fabulous partner, a community partner. And then the date of the next regularly scheduled board meeting will be Thursday, October 6th, again via Zoom. And we will ask for a motion to adjourn. And Mary Dawson, seconded by David Mallion. Thank you. And I assume nobody's opposed. All in favor? Perfect. Thank you. So why don't we jump? I believe David and team will be in a media scrum for a few minutes. So why don't we take 10 minutes and then we will jump back on at 6 o'clock for the in-camera session. Wonderful. Thanks, everybody, and welcome to the new school year. Good luck to all the kids out there.